All right, can you hear me okay? All right. All right, I'm Dan Matlock. I'm actually a geriatrician here on campus. And I'm going to talk about the DECIDE-LVAD trial as an example of a step wedge design trial. And it's such a luxury to present before the statisticians because then I don't have to make up answers to hard questions like we do at annual meetings and such. Another true confession. I think Larry Allen is the PI of this trial. He's in Alaska texting me pictures of glaciers as of this morning, so he's not here to present, so I'm going to present for us. So a little bit about, just generally about shared decision making. This is not what shared decision making is. It's not just giving patients options and then letting them make a decision. My favorite definition of shared decision making is a meeting between experts. There are a lot more precise definitions, but I like this one because it acknowledges that shared expertise of a patient and a clinician. And that's important when you think about designing a trial because we're not just designing for one person, we're designing for a group. We make these tools that I'll tell you a little bit about, but we want to really influence a conversation between a patient and clinician, or patients and families and multiple clinicians. So these are not little one-off interventions. These are groups that we're intervening upon with these tools that we make. And this is a complicated side, but we go through a lot of work in our development of designing tools for dissemination. And I think this is part of a pragmatic design when you design an intervention, is you design something based on stakeholder input and empathy to the end users. And you see these two circles here where we rapidly prototype the tools we make based on feedback from people. And I think this is partly another piece of pragmatic trial design is actually when you design your intervention, are you thinking about the end users even ahead of time? So we've made paper tools. These are from our defibrillator work. We've made video tools. We have a website where we put our tools out there and make them freely available. And these decision aids, when they're studied in efficacy trials, they almost always work. There's a Cochrane review of 115 trials of decision aids, and they improve all of these things: knowledge, value treatment concordance, doctor-patient communication, involvement satisfaction. They lower decision conflict, they lower decision regret, and they lower the proportion undecided. And so you'd think this is a highly efficacious intervention. These things work really well. But then implementation of these things is really, really hard. All kinds of simple little questions are very difficult to answer. Who's going to deliver the decision aid? Is it going to be done by the provider? Or is it going to be done by a staff member? And if so, then is that staff member empowered enough to actually provide the decision aid and have the discussion on behalf of the provider? Do the patients want to hear from somebody other than the provider? And then how will you deliver it? Will you deliver it electronically? Will you mail it? Will you deliver it by email? Is it in person? Are you designing a tool to be used during the clinic or afterwards? And I think one of the things that we in the decision aid world have sort of ignored is that different decisions are different. One model of a decision aid doesn't fit all decisions. We have a 26-minute video for patients with an LVAD, which I'm going to tell you more about. But a 26-minute video for some of the primary care decisions that I do is totally unrealistic and frankly ridiculous. And so you can't just say, oh, we know how to design decision aids, because these decision aids interact with the context, like we talked about yesterday in the D&I group, and you need different designs for different contexts. And then one of the hardest pieces is when is that patient actually in their head making a decision when the decision aid would actually be helpful? I have a colleague who made a decision aid for stents, for patients getting stents, and he employed it right at the time they're going in for their procedure. They're like in a gown, their bottom's hanging out. They've kind of already decided they're going to go through with this procedure. Decision aid's not quite, it fit the nice informed consent model, but it wasn't really the time when that patient was in the decision space. So this little model at the bottom is what we thought of for our defibrillator work. It's probably not after the PCP. It's probably somewhere between the cardiologist and the electrophysiologist, but it could be in all these other spots. So designing when to deliver the interventions are really hard. And this is a systematic review that actually, Carmen Lewis sitting in the back was a co-author on this paper, but they reviewed all of these trials of decision aid implementations, and the title summarizes it nicely: many miles to go. And clinicians were concerned about the content of the decision aids. They were concerned that decision aids would disrupt workflow. And then lack of incentives was a major barrier. So a little bit about our LVAD tool and then the step wedge trial we ran. So we designed an LVAD tool with our iterative stakeholder design, as we talked about. I'm not going to go into the details of the decision aid, but I'm happy to if somebody wants to talk about that later. But the LVAD, just for those who don't know, just to give a little context for why we designed it this way, this is one of the high stakes decisions. This is basically the modern version of the artificial heart. The medical field has been playing with artificial hearts for almost 40 years now. There's Barney Clark, who got an artificial heart in 1982 and lived for 112 days, and he got a fully artificial heart. So these days, they keep the heart in and they take this pump and kind of plug it into the heart. They crack the chest and you stick it into the ventricle, suck blood out of it, and stick it into the aorta and pump blood to the body, and you get more cardiac output. And then you have this little wire that sits on a battery pack here. And then the patients wear this battery pack and this controller, and that's what the modern artificial heart is. And they're working pretty well. The 1 year survival goes from about 1 in 10 to about 8 in 10 if you get one of these, but that comes with a whole lot of side effects. 3 in 10 get a chronic infection because you have this little wire connected from the outside dirty world to the inside clean world. About 3 or 4 out of 10 get a stroke in that per year, or 1 out of 10 get a stroke per year. About 3 out of 4 or 10 get rehospitalized. So the big benefits and big risks. And there's Vice President Cheney. He had one of these procedures for a couple of years before he got his heart transplant. And these are growing. These are now more common than heart transplants. Heart transplants, the number of them is kind of flat that become available each year, whereas this is not a scarce resource. I mean, you can argue that it's not you're not waiting for transplants. You can make more of these even though they cost around $300,000 each. But they're now more common than heart transplants. And so they're growing. So then I guess this was 2014, we developed the tool and wrote a PCORI grant, and we're funded for the DECIDE-LVAD trial, which is the trial with the step wedge design I'm going to talk about. And it's a combined, we called it a type 2 combined effectiveness implementation hybrid design. We didn't want to do a little patient level efficacy trial. First, we know those kind of work. Second, LVAD patients are not like hypertensive patients. The hospital has 30 or 40 a year. So, to even power up an efficacy trial would take a long time. So we wanted to look at effectiveness while also trying to figure out how we'd implement this. And so we had these dual aims of looking at both of those. And we considered a few designs. I've already kind of talked about the classic patient level randomization, but for these shared decision-making interventions, it's kind of hard to imagine that that's the right design. Because it is a dyad, we're trying to influence a conversation. And so already you've got a cluster, and if you just intervene on the patients, then you're gonna risk spillover effects from those clinicians to the non-intervention patients that they would see in the trial. And in the case of the LVAD, it's really not even just a patient and a clinician, as in my primary care patients, but it's like a site. These heart failure teams are teams of people that work pretty close together, and they have meetings every week about who should get a transplant. So the spillover effects would be really concerning. So we really needed a cluster, we felt, of some kind. So we considered a cluster randomization, but again, it's a PCORI grant. It was a nice sized grant, but even looking at the budget, we could afford about 6 sites. We knew we had to be on the ground with these sites, really helping them implement. So we weren't sure that 3 intervention sites and 3 control sites would be enough to really have a cluster randomized trial, although I've certainly seen some, we've seen some in the literature, and I've been a part of some. It just gets a little dubious. So we moved to a step wedge design. And the way our step wedge design was done, we had 6 sites, but we had 4 steps. We didn't completely randomize the sites. We knew we had run a 10-person feasibility pilot trial at Colorado. And we already had this effect where some of the nurses on the floor would give patients the decision aid and give them the videos. So we were concerned about spillover effects already. So we made the coordinating site the first site to roll out the intervention. And then we had two smaller sites and one larger site, and then we randomized those. And that's how they came out. And then every 4 months, we would roll out the new intervention at each of these sites. We use the RE-AIM framework for evaluation. I think many of you are familiar with this, but just very briefly, this is the framework that Russ Glasgow and colleagues developed. It's a really nice framework to organize thinking around other measures other than just looking at effectiveness. But the REACH is the percent of eligible patients and caregivers that get the decision aid. The effectiveness is the primary outcome was decision quality, which is this combined outcome I'll talk about of improving knowledge and value concordance. Adoption is, did the sites adopt it, which is a little artificial in a trial where all 6 sites agreed. So we had 100% site level adoption, but even within the sites, did each of the clinicians adopt the intervention? And then implementation, how was it consistently used? And then maintenance, after we were done, did sites continue using it? The way we implemented it, we had a little bit of a pre-implementation phase where we would go to the sites and kind of plan who's going to do this. And then at the time of the step, Larry and Colleen, another person in our trial, would travel to the site and they would give a grand rounds, and then they would have a 1-hour communication training with the heart failure team, and then a 1-hour sort of nuts and bolts conversation with the team about how are you going to implement this. We were really lucky in this space compared to other decision aid interventions where they already have a team, they're in the ICU, they're captive, and they're handing them industry materials. So we didn't have to develop a whole new process for intervention delivery. They could just unplug the industry materials, which they didn't really like, and then use our tools instead. So in contrast to a lot of other shared decision-making interventions, it was actually easier to implement. And then at post-implementation, we had ongoing site support as they had questions, and we did a follow-up visit to look at implementation and how it was going. Our primary outcome was decision quality. A little bit about decision quality. This is something that's put forth in a lot of the decision aid literature of, can you increase knowledge and value concordance? If you have a patient who has better understanding and the decision is more concordant with their values, then you've improved decision quality. So on the lower left would be low decision quality. And if you can move people up and to the right, you've improved decision quality. It's defined as the extent to which a medical decision reflects the considered preferences of a well-informed patient. That's one definition of it. The knowledge is easy. We don't need to talk about that. We just had a few knowledge questions, but the way we measured value concordance is worth talking about a little bit. We had them put an X on a line, and on one end of that line, they said, would you want to do everything you can to live longer, even if it means having major surgery and being dependent on a machine? Or would you rather live with whatever time you have left without going through major surgery or being dependent on a machine? And so if you put an X on that end of the line, you should get an LVAD that's concordant versus the other end. And vice versa, if you put an X on that end of the line and you ended up not getting an LVAD, then that would be a discordance. So in the trial, we had 248 patients. There were 385 eligible. We'd planned to enroll 168. That's what we needed for our power. And because I showed you that trend of increasing LVADs, when we did our enrollment numbers at each site, we did it based on 2014, but then they increased their volumes. So we actually over-enrolled, which is a great problem to have, but in a stepwise design, you can't stop when you meet your enrollment target. And we were paying sites per patient enrolled. So we had to re-budget to find money to continue to pay them to over-enroll. So it actually was kind of a problem. It's a good problem to have, but it's something to think about with stepwise designs, depending on how you do it. You can't just, like in a traditional trial, you can stop when you're done, when you've reached your target. You can't in this design. You have to keep going. And that's one of the things that is not a great thing about stepwise designs, actually. So at the sites, we had all sites participated in the training. We had really great reach for a decision aid trial. 88% of the patients in the intervention arm got the pamphlet decision aid, and the 92% actually got the video decision aid. And in general, patients felt the tools to be a little bit biased towards the LVAD. In the control group, that was 54%. In the intervention group, that was 43%. That's been important because a lot of the clinicians think they're biased against LVADs. So we like to point that out, that that's not what the patients think. And then we did improve decision quality. We had a small improvement of knowledge of about 5.5%. And then a pretty large improvement in value choice concordance, the Kindle-Tau correlation of 0.28. And then secondarily, we had a pretty large reduction in the rates of LVAD use at the sites, which they'll talk a little bit about. I think some of this, I think, is a function of the trial design. Some of this may have been secular trends under the trial, where as the trial went on, people started using the decision aid earlier in the course of illness. So, you randomize the rollout to sort of control for secular trends, but we still saw secular trends. So it wasn't perfect. But some of this is probably intervention effects. And interestingly, when we submitted this to JAMA to have a co-presentation with the AHA, so we were trying to do that fast thing. And both reviewers at JAMA were clinical trialist reviewers almost certainly, and said, well, you didn't do fidelity assessments of your intervention, so this isn't really valid. We don't know if they got the pamphlet. And by design, we didn't tell sites that they had to do just the paper, the video. This is part of the pragmatic design. We let sites deliver the intervention how they wanted. And research staff were not allowed to deliver the intervention. They were sort of a fly on the wall study design where they would watch and see how it was being used, but they were not involved in the intervention at all. Those were some of our pragmatic choices of, could we convince sites to actually do it on their own? But that kept us out of JAMA, and we ended up in JAMA Internal Medicine, which we're very happy with. But it does get into, when you were reflecting on your challenges getting published, I mean, these designs don't fit the traditional model, and you don't really see that until you kind of talk to a traditional person of some kind. Anyway, I'll turn it over there to Erin and Diane, who are amazing to work with, and go from there.
Just okay, good. So this was actually my first stepped wedge trial. I've talked to a lot of other people about subsequently designing these studies, and so I've incorporated a little bit of that feedback and interaction into this presentation. But I'm going to confess to quite a few naiveties and things that I assumed that were true that weren't true, that I learned, and kind of as a result of all this process, I actually ended up developing kind of a little checklist that I use when somebody walks into my office and says, oh, I heard about this great design, and I can have less sites and less patients. And, I really want to do this. And, we start getting down to the nitty gritty, and sometimes it comes to, we decide that maybe this isn't the right design. So real briefly, I'm going to call it quasi-experimental. It's a hybrid of a cluster randomization and a crossover. And the crossover is unidirectional. So each of these rows is either a cluster or multiple clusters. And then you have these time periods, and you randomize sites in terms of the time at which they cross over. There's two versions. One version is what we refer to sometimes as cross-sectional. And that's basically in each time point, you're you're enrolling new patients. So you may have, 10 per site in the first time period and 10 per site in the second time period going on. There also is a cohort version where you start everybody off at the same time. So everybody's enrolled at the beginning, and then the time in which they cross over to a new type of treatment is randomized. I'm not going to talk about that at all. I don't have any experience with it, and it really has a number of different issues. And if we had a day, we could go into both designs, but we don't. So, so what are the reasons you want to choose a step wedge design? I would argue that if you're really trying to assess efficacy, you're doing the first phase 3 trial, this is probably a very risky strategy. But if you're trying to understand the effectiveness or particularly the implementation, it's a good design. And particularly when you've shown efficacy in another setting, maybe a controlled randomized trial or something that has very specific sites, academic sites, and you're trying to see how does it generalize to all the practices in Colorado. The advantage with implementation is often that you can now, as Dan was talking about, you can study what's going on when a site tries to implement this as a policy. If you do all of them, you don't have that ability to observe. And there's also some training issues that happen, and if you can't manage to train all of your sites at the same time, you have a pragmatic reason for doing these. So, kind of going into a little bit more detail, you know, there's some efficiency of doing this because the units, clusters, whatever, act as their own control. So if there is some site-to-site variation, your statistical model can take to some extent into account for that. And that's going to generally lead to smaller cluster sizes, particularly if you have a large interclass correlation, which means that there's a lot of variation between the sites relative to the within subject variation. I mentioned the logistical and the financial, and another, you know, underlying thing is if all the sites feel like they're going to get the intervention. This is particularly true if there's a little bit of a lack of equipoise, that at least in the efficacy setting, that something has been demonstrated to be efficacious, then, you know, they don't really want to be in the control all the way through. It's a little bit harder to randomize the sites. So this is the statistical model, and it's kind of the classic one that's proposed for these models. One of the important parameters is this theta, and that's your treatment effect. And the Xij is basically an indicator of whether the patient in the ith cluster and the jth time period received the intervention or not. So it's a 0-1 indicator variable. Notice that the beta, there's a beta j in there, and that is the variable that controls for the time effects. But notice that it's constant across clusters. And this is a very critical assumption underlying these trials, that you believe that if there's anything that happens, you know, like Medicare changes their way of reimbursement, it happens to all the sites at the same time, and that would be a time effect. But if you had something that, you know, really dramatically changed, and it happened at different times in different sites or only in some sites, this would violate one of the assumptions of this model. The other two things are this between cluster variation, how much difference is there between the sites, and then the within cluster variation, and your interclass correlation basically is how correlated are individuals' responses within the same site. And in a cluster randomized trial, the power is very, very, very sensitive to that. But in the step wedge, it's much less sensitive to that. So this is just one example, and then I picked one that showed it fairly dramatically. This is 6 sites with 6 steps, maybe 5 steps, no, 6 steps. 70 subjects per site, an effect size of basically a half a standard deviation. And you can see that the power with the stepped wedge design is fairly insensitive to the interclass correlation, whereas the power, just really, really drops when you get up to interclass correlations of 0.1, which is not infeasible in some settings. So what are your key considerations? Well, I've alluded to this, but are you trying to demonstrate efficacy? I would say this is a risky design. Demonstrate effectiveness in practice, it makes a lot more sense. An assessment of implementation, that really puts it up on the higher, more likely to go to the step wedge design. What can be your unit of randomization? I mean, if your intervention is at the individual level, it is possible to randomize at the individual. But if you're actually changing something in practice, then you can't do individual randomization, and you're into the cluster issue. But this is a little bit more subtle, but it's actually very critical. And I wasn't totally appreciative of this 5 or 6 years, 6 or 7 years ago when we designed this study, but I've become much, much more sensitive to it. And how and to whom is the intervention delivered? Is the intervention delivered to the individual, or the physicians, the clinicians, the practice setting? And how? In the LVAD trial, we basically had a single contained encounter in which the decision aid material was delivered. But let's say you had another intervention in which you had 8 sessions, a behavioral intervention that took 8 sessions. That's going to be a lot more problematic, because if over the course of those 8 sessions, you get contamination because you change from the control to the intervention, you've got contamination, and that's going to be a problem. So shorter or sweeter, or if it is long, there has to be something that separates the people in the control period from the intervention period as you cross over. And how and whom is the outcome measured? Is the outcome measured almost immediately after you do the intervention, or is there follow-up? And if there's follow-up, is there going to be contamination during that period of follow-up? So those are the, as a statistician, those are the questions to really start probing as you start talking to investigators about this potential design. So in the DECIDE, this is probably one of the best matches to this kind of design. We were looking at effectiveness and implementation. Our unit of randomization had to be the clinic or the site. How was the intervention delivered? Well, it was to the patient caregiver that was supposed to be in there, and in a single encounter. So that helped with the feasibility. And how and in whom is the outcome measured? It was the patient, the caregiver, the timing was interview pre-post, 1 week, 1 month, 6 months, and 6 months is fairly long follow-up. And so the question there is, you know, when other people are being treated with the intervention, are you going to contaminate the control patients? And in this setting, that seemed fairly unlikely. So what are the challenges? Some of them are fairly obvious, and we recognize them early on. Starting and ending accrual and follow-up at the same time in all sites. So you need to coordinate not only IRBs, but subcontracts. I think we had a little bit of a delay because of subcontract negotiations. And important commitment of all sites to complete the study. You have sites that drop out, and you're losing the intervention. You're not losing both control and intervention. You're losing intervention subjects because they're in those later phases. You need study recruitment that is consistent with selection of your patient characteristics. So you don't have selection bias. You either need very, very, very large pool or renewing pools of participation. We thought we had a renewing pool because we would have these new patients consistently coming in and being assessed for their LVAD. We did find out we had some changes in that patient population over time. But another thing is, how many times have you had a trial where, you know, you recruit patients during their clinic visit? Well, sicker patients that have a chronic disease the sickest patients are going to come in more frequently. And so you're going to end up getting the sickest patients early on. And as you pull them out, you're going to have to be dipping into some of your more healthy patients. Those are the real threats to the kind of validity of this. And I found I need to probe about these issues. And then any limiting to sites where you don't think that temporal changes are going to happen, though they will. So this is actually our enrollment table, and there's really two things to kind of take away from this. One is if you look at the total enrollment, you can see that it kind of drops down a little bit over time. Now maybe part of this was our funding issue, but you know, and the other is trial fatigue, and it's important that we don't do that, but it did result in a slightly smaller number of individuals in the intervention group than a control group. Fortunately, we over-enrolled, so we weren't in trouble. The second thing is you notice that we had at least two characteristics that we observed. Forget about the unobserved potential things that might have confounded this. And we noticed that we were recruiting more and more from outpatient clinics than from hospitalized patients. And we were recruiting more people that had earlier diagnosis over time. So we did have a changing population over time. You know, under the assumption that these things were influencing the study equally by putting them in as covariates or actually having the time varying and that beta J that I had in the first model, it should take care of them, but it's definitely something to worry about. And Erin's going to talk a little bit about some other things. The third thing that I should mention is, and this was my naivety, is if you remember Dan's first slide about what the design looked like, he had this diagonal where we were going to kind of stop accruing information on patients during the period that we were going to do the training, and you might do that if you have to do some follow-up or you need some washout. There's a number of reasons for that. And at first I was very upset when I saw that, and I said, oh, they didn't do it the way we said we were going to do it. And then I found out that that was a blessing in disguise, because the sample size power is not solely dependent on the number in the control and the number in the intervention or the numbers at each site. But there's a very important issue about when you insert that wait list. And I just naively thought, hey, I have the same number of patients. I have the same, it's just a little time lag. Not so. So that's my big lessons learned in my confession. So this is one of the challenges, and I've been referring to this, when there's going to be contamination, you may need this washout or rollout period, but it actually has some serious implications in terms of your power. So what are the analysis issues? And I'm just going to go through these fairly quickly, but I'm going to talk about ones where the unit of observation is the individual, that your distributions of your outcome are, the usual normal, continuous, binomial, Poisson and Cox. We can use this generalized linear mixed model that was described by Hussey and Hughes. And there are some variations. Hemi talks about that in the 2017 trial. There's references there. You can add covariates. We did that. You can do repeated measures within individuals. Well, we actually had repeated measures within individuals. You can think that treatment effect varies by time since interventions started. We didn't do that. You can have cluster by time, cluster by treatment, and treatment by time effects. Some of these may not be estimable. They may be over specified. So you need to think those through. You may need multiple clusters per step to do those. And another one is that they changed that the beta J to a fixed effects for clusters, and that actually reduces to a general linear model. So there are some variations on the analysis models. Then in some of the trials, you don't have data at the individual level, but you have data on the at the cluster by time interactions. So in that case, you may be looking at immunization rates in that particular time in that cluster, or some other thing that you can get from other sources or state databases, something like that. And that's a linear mixed model. And then there are some people that talk about doing GEE models, and when they implement them, generally their outcomes are binomial, and they specify a working covariance structure rather than estimating it. So summary, to step wedge or not, there are a fair number of recent discussions. At first it was all trying to get people to think about this as a design. Now there's a little bit of, a reality check pullback. But you can see that most of these are really pretty recent. I have a manuscript. I haven't gotten it published yet, but that's why the question. And it's basically lessons learned from the LVAD. One of the things that I like I said, I kind of developed this checklist, and I've talked about many of these things. And this is just kind of summarizing it and organizing it so that if I'm sitting down with somebody, I may just print out this page and just kind of go through it, make sure I've covered all the points. You know, it's starting enrollment at the same time. All the sites are going to complete. Will the sites be committed to doing, you know, fairly even enrollment over time? Really wide variations in how they enroll can affect the design. But this is one I really talk very detailed about. Is the pool of potential participants, or some way that we're going to avoid bias selection over the course of the study. And that probably kills about 50% of the studies where I've had the discussion. And this is the other one that is the duration of the intervention short enough to avoid contamination. It's all about this, when you do the crossover, you know, are you going to get contamination? The other ones, both of these are really about that crossover and contamination. And are there events or changes in policy that might result in time trends that are likely to occur at some sites and not other sites? So that one's a little bit harder. So I'm going to turn it over to Erin, who has taught me more about this design through her research.
Thanks, Diane. It's been really, so my name's Erin. I've been at Accords since late 2014, and I've been really happy to be able to have worked on the DECIDE trial with Dan and Larry and the whole team. I've learned so much, and it's been lucky for me because it's this design has really led to a lot of research questions as a statistician that's helped me move forward in my dissertation. So today, my section of this talk is going to be short, but we're going to switch gears a little bit, and we're going to talk about different considerations for power and sample size calculations that you might want to think about if you're planning your own stepped wedge trial. And I'm not going to go through a lot of statistics or formulas or things like that. There's a lot of great references in your workbook, yeah, a lot of papers. The two main papers that I might point you to if you want to look into the background for some of these formulas are the Hussey and Hughes paper that Diane mentioned, and one of the articles by Dr. Carla Hemming, and that one's titled, the best one for the sample size is the one that's titled A Unified Approach. So that's in the references in your workbook. But I'm going to go over a few of the main things that you might want to think about when you're thinking about developing power and sample size calculations for your trial, and then I'll take you through a few examples of things that Diane and I have learned along the way from DECIDE and then from my dissertation research. So power and sample size calculations for stepped wedge are similar to power and sample size for cluster randomized trials or even individually randomized trials, in that they depend on a lot of things. They depend on the strength of your treatment effect, the number of clusters you have, or the number of participants, and then how variable you think these outcomes are going to be. A couple of things that I'm going to talk about on the next few slides are different things specific to stepped wedge, like the number of clusters you want to have at each step, and then a few design variations that Diane and Dan have already talked about. So first of all, just stepping back a little bit and talking about differences between stepped wedge versus cluster randomized trials. Diane already showed you that slide early in her talk where you can see that the stepped wedge design isn't as sensitive to changes in the ICC as the cluster randomized trial is, and that the stepped wedge can be more efficient. And that can mean fewer number of clusters or fewer total participants or both than the CRT when you're at these larger levels of the interclass correlation. However, and Allie mentioned this at the very beginning, is that you still want to have more, more clusters is better. You really we still want to have as many clusters as you can have when you're designing these trials. And there's a couple papers that are pointing out, a couple recent papers that have pointed out some of the risks for studies, particularly stepped wedge and cluster randomized trials that have a small number of clusters. Point you to the paper by Taljard, and one of the main issues is, of course, limited generalizability, and you have some increased risk for errors and other things like that that you want to be concerned about. And then there's another paper by Barker et al. Where they go into some more statistical and simulation detail about recommendations for the minimum number of clusters under certain settings. And so it's just a good thing to keep in mind, is that you really still want to have more clusters than fewer clusters when you're doing these stepped wedge. So now I'm going to spend a few minutes going over a few different example stepped wedge designs and looking at some places where you can have increased or decreased power. And these are all things that Diane and I have learned along the way as we've been working with the DECIDE trial, as well as working with the Accords investigators to potentially develop new trials. And so I have a few just example stepped wedge designs that we'll talk through. I'll just try to orient you to the pictures that I have here. So on the leftmost column of each of these pictures, the numbers are the number of clusters that appear in that treatment sequence. So you can have one or more clusters be in each row. And so in the very first diagram at the top left here, this is an example of a stepped wedge design where all of your clusters, all 6 clusters, each one rolls over to the intervention at its own step. And this is the design that has the most power that you can have for your stepped wedge design. And that's in contrast to the diagram on the top right, where you have a fewer number of time periods, and you have 2 clusters rolling over at each step. So in the Chaussee and Hughes paper, they have a great example of this, and there can be drastic differences in the power that you achieve, even when you have the same number of clusters. See, both of these examples have 6 clusters, but the maximum power is achieved when you have each cluster roll over at its own step. Moving down to the next example, if you have a fixed number of time periods and you know that you need to have some clusters roll over at the same time, a paper by Laurie et al., they showed that you have optimal power when you have the most clusters roll over at the start of the study and at the end of the study, and that gives you better power than if you have, for example, a case on the right where you actually have an equal number rolling over at each time. So that's just something that Diane and I learned along the way that we thought was interesting that we'd pass along to you. And then next, I'll talk a little bit more about the example that both Dan and Diane were talking about, where in some cases you might need to have a transition period in your clusters in between the control period and the intervention period. And this can drastically decrease your power depending on your other parameters, like your number of clusters and your ICC. So in this case, if you need to take that whole time period and not have anybody enroll or any data collected, this can cause a very big decrease in power. Sometimes you really need to have this, but it's something to really think carefully about. You don't want to just say, oh, I have the same number of subjects, I'm going to have the same power. That's not the case. So it's something to really consider when you're designing your study. And I'll give an example of that on the next slide. But another thing that Diane and I found as we've been going through the literature lately is what's called a hybrid design. And you can actually get additional power over a stepped wedge design if you think about nesting it within a cluster randomized trial. So this is the diagram at the bottom. So in this case, your first set of clusters are all on the intervention, and your last set of clusters are all on the control period, but in the middle you have this stepped wedge design, and this can be something that can help out with your power, and it might be something that already might work for a study that you're working on. If the institution you're at is already using a certain set of materials or a certain set of treatment, you might consider a design like this. So just going back to this transition or washout period design, this is an example that I've been working on recently to show really how much power is lost or how many more additional subjects you might need if you go with this transition period. So if you have a complete design, meaning it's more of the standard stepped wedge design like the one on the top left where you have enrollment at all periods, the example trial that I'm going over has a grand total sample size of 840, and that achieves 80% power. Now, if you just shift everything over to the design on the right, where you have nobody enrolling during that transition or washout period, but you still have the same number of subjects overall, you still have 840 subjects, your power can drop to 66% in the example that I'm showing here. And then if you move to the bottom row of the table, in order to get back up close to the 80% power, you need to enroll over 1,100 participants to make up that difference if you want to use this type of design. So Diane and I didn't know at the start of our work with this that this loss in power could be that substantial, so we just wanted to give you the heads up if you're designing your own trial. And then finally, we wanted to end with giving you some resources for you as statisticians, or to give your statisticians for some stepped wedge power and sample size calculation tools. And there's a couple great packages in R. The first one up here is developed by Jim Hughes of Chaussee and Hughes. And it does basic power calculations for the stepped wedge design that he talks about in his main paper. And it also does a few design variants like we've talked about just now, including the incomplete designs. The bio et al. Paper package, SW-SAMP, is very flexible. I haven't used it in a few years now, but it's also a good option if you or your statistician program's in R. And then there's a web application developed by Dr. Carla Hemming and colleagues, also with input from Jim Hughes, and it actually does both cluster randomized and stepped wedge, and so that's a good resource to look at. Dr. Hemming also developed a Stata package, and the most recent versions of PASS also do these types of calculations. And most all of these are based on the Chaussee and Hughes linear mixed model that's described in their paper, and they are all, just as a reminder, these are all the cross-sectional stepped wedge designs where you're enrolling new groups of patients at each time period and you're not crossing over with an individual, like Diane mentioned. So these are all these are all using those standard models. And then here's our reference list for the things that we talked about today.